is the routine for neonatal examination in the hospital, but a lot of what I'll go through is very relevant to yourselves because, you know, obviously you will see these babies if there are problems at 1 week or 6 weeks or whatever it might be. So, you know, I'm going to go through the routine that I go through with the residents and registrars here at the hospital and the midwives, but I will outline a few points that are very relevant to yourself. Now, you did get a handout, and on the handout I say please have a little look at the prenatal history before we start the routine examination, because often the prenatal history will give you some idea as to, are you comfortable there? Yep. Give you some idea as to what you might find. For example, if it's been a breech presentation, there's a 10% chance of dislocated hip. If it's been a difficult shoulders delivery, which is not uncommon in big babies, there may be an herb Duchenne palsy or a fractured clavicle, not that uncommon. If the baby's had a very low 5-minute APGAR score, and the 5-minute APGAR score is fairly relevant, then the baby may be neurologically compromised. All of those things are relevant. And then there are lots of things that lead up to the history as well, you know, with ultrasound. I mean, the common one that I'm always asked about is renal pylectasis, and I'll comment on that a little later on. It's not immediately relevant, but, you know, what we do with mild degrees of renal pylectasis is probably very, very relevant to yourselves. So, the examination that we go through is, firstly, we just look at the baby, because most little newborn babies are in a position of slight flexion, slightly flexed arms, slightly flexed legs, and before I disturb them at all, I just have a look at their breathing pattern, because as soon as you touch a little baby and disturb it, it'll start breathing rapidly. So it might be difficult for you to pick up mild degrees of tachypnea if you've disturbed it. So just have a little look at the baby, and then I quickly look fingers and toes. So I have a look at the toes, have a look at the foot creases, have a look at the fingers, make sure all of the fingers are there and present, that there are no obvious skeletal anomalies. Have a look at the palmar creases, because in chromosomal abnormalities, a transverse palmar crease without any intersecting lines is so-called simian crease is very important. So have a look at those. And then the other dysmorphic features, which you generally look at initially, are usually around the head and neck. For example, we look at the eyes. They may be slanted that way, which is in Down syndrome, or they may be slanted that way, which is referred to as an anti-mongoloid slant. The eyes may be close together, which is hypoteliorism, or they may be far apart, which is hyperteliorism. The ears may be low slung, and normally we would like to see the upper third of the ear level with the angle of the eye. Those babies that have low slung ears are well below that level. The baby may have macroglossia, meaning that the tongue is big and sticks out. Now, a lot of normal babies will stick their tongue out, but as soon as you touch it, they'll pop it back in again. Whereas the baby with macroglossia will have this big tongue, and it's difficult to get back into their mouth. They may have an underslung jaw, so that's micrognathia. So all of these are dysmorphic features that may be relevant before you actually get into the nitty-gritty of routine examination. Then, having done that, the examination starts at the top and just moves down. So I usually have a look at the anterior fontanelle, which can vary in size from the size of my thumbnail up to a 20-cent piece, and sometimes it can be big enough so that it V's down in this metopic suture right at the very front here, and you can feel this little ridge in the forehead, which is the metopic suture. With the sutures, you you can spring the sutures, meaning that as you press on them, they spring either side like that, and it's not uncommon to have a little bit of separation of the sagittal suture, perhaps half a centimetre or so. It's a little unusual to have any degree of separation of the coronal suture. If you had separation of the coronal suture together with perhaps a big anterior fontanelle, it might indicate that there is raised intracranial pressure. But it is a little unusual to have separation of the coronal suture. The other interesting thing that you're often asked about, and parents often say, oh, what's that lump in the back here? There's often a lump in the occipital area, and it's where the occipital suture meets the sagittal suture, and you get tenting up of the sutures in that position, and it presents sometimes a bit of a lump in the occipital area, and we just reassure the parents that that is fine. With vacuum extraction, and there are a lot of vacuums these days. I haven't seen a forceps delivery. Well, I have actually one forceps delivery in the last few years, but we don't see very many forceps deliveries. But there are a lot of vacuum extractions, and you can get some bruising around the scalp with vacuum extractions. We have actually had a few babies with quite significant scalp trauma from vacuum extractions, which I won't go into too much, but subgaleal hemorrhage has been one of them, where there is an enormous extravasation of blood in the subgaleal space, which spreads right down and around the neck and gives a boggy mass in this occipital area. But the simpler things that we see are head moulding with caput succedaneum, and caput succedaneum is subcutaneous edema, so it's pitting on pressure, in contradistinction to a cephalhematoma, which is subperiosteal bleeding. There's just bleeding under the periosteum and is located to one bone, so it doesn't cross the midline, and it's fluctuant on palpation. And I think it's important in the initial stages in hospital for us to determine whether it's caput or cephalhematoma, because caput usually settles in 3 or 4 days. Cephalhematoma may take 3 or 4 weeks to settle. And it can be relevant in your situation because a good sized cephalhematoma can accentuate physiological jaundice. So, you know, you get a baby who gets mild physiological jaundice on day 7 to 10 or so, goes home, and then it's still jaundiced when it's a couple of weeks old. It's got this great big cephalhematoma which has accentuated its jaundice. So important to tell the difference between cephalhematoma and caput succedaneum. And I should have mentioned also, in measuring the head circumference, it is not uncommon for me to get a call from staff saying, oh, the head circumference has changed, it's increased by a centimetre or so, and that obviously is related to head moulding, so that, you know, we can see these babies and they have their head circumference measured when they're born, and then 2 or 3 days later someone measures the head circumference and it's gone up a centimetre because the sutures have sprung and there's been a bit of overlapping of sutures that have sprung the head circumference out a little bit. Okay, so the only other thing in head and neck which we tell the residents and registrars to do is just have a look in the eyes, and we usually just have an ophthalmoscope set on 0 and have a look to get that orange reflex. Now, I say that I've spent a lifetime looking in little babies' eyes and only come across congenital cataracts on 2 or 3 occasions, so it's not something that you're going to come across very often, but it's good to be able to get that nice orange reflex. And the other thing that I usually do is stick the finger in and have a feel of the palate, just to make sure that there is no evidence of a cleft palate. All right, having done that, I go through their basic reflexes, which are moro, and to elicit a moro, I mean, some little babies are so acute that you can go like that and you'll get a complete moro. And when I talk about a complete moro, I mean extension and flexion. Extension and flexion. And when we talk about an incomplete moro, which you may see in a sleepy baby or a baby that's neurologically compromised, you might just get a very weak extension with no actual flexion. In eliciting the moro, I usually just let the head drop back and the body drop back slightly. And I'm looking for that full extension and flexion. So moro, grasp, and the baby should be able to grasp your fingers almost to support its own weight before the grasp breaks. Almost. Those that are very hypotonic, of course, you don't get any good grasp at all. And suck response we've gone through when I've felt to see if there is any abnormality of the palate. Okay, so that's head and neck. The only other thing I tend to do is I tend to sit the baby up and just make sure that there's no evidence of any head tilt to one side. Because occasionally, you know, little babies are in utero like that. And then you sit them up and they've got head tilt to one side and they may be a little bit tight in their neck muscles on that particular side. So I just usually check to see that if the baby's got any head tilt. All right, moving down, feel the clavicles, and as we've commented, you may, and it's not uncommon, have a fractured clavicle in a baby that's been a difficult shoulders delivery. Normally the obstetrician can tell us because they say we felt a crack when we try to get the shoulders out. So I feel the clavicles and come down, feel the pulses, including femoral pulses, and look to see if there is any chest deformity. I have a listen to the heart. Basically, any murmur in a little baby, in a newborn infant, is probably relevant. And I say that because in the newborn period and even during the first couple of weeks of life, pulmonary artery pressures are elevated. So I point out to the staff, the residents, that a very soft systolic murmur may, in 2, 3, 4 weeks' time, be a rip-roaring 4 out of 6 pansystolic murmur of a VSD. And the reason being, of course, that in this early neonatal period, pulmonary artery pressure, pulmonary right ventricular pressures are elevated. So you've often got a right ventricular systolic pressure of, say, 85 or thereabouts, compared to the left ventricular systolic pressure, which might be about 90. So there's only a small gradient across the between the two ventricles. And then as the right ventricular pressure settles down to about 25 or so, that increases the gradient. So if you had a left to right shunt, it becomes quite significant. So any murmur in a little baby, I think, needs to be followed up. So we have a listen to the heart, that we've felt the pulses, listen to the chest, make sure there's good satisfactory air entry to both sides. And we're moving down to the abdomen, and I'm going fairly fast, I know, but and we say that little babies' abdomens always look a little bit distended, especially if they've just had a feed. But you know, I think that's pretty normal. So we examine the abdomen, we check the groins to make sure that there are no herniae or no masses in the groins, and then palpation of the abdomen. And I usually just recommend to the staff flat hand palpation. Instead of doing that, which makes the little baby reinforce against you, I usually just like to have the flat of my hand and just go over the abdomen like that, and you can sense in that part of your fingers if there are any masses or resistance to your palpation. The liver edge may be palpable about 1/2 centimetre below the right costal margin on that side there. The kidneys are usually difficult to palpate. I think those who do a lot of palpation in little babies can probably bimanually palpate the lower pole of both kidneys, but it can be difficult. Okay, come down to the genitalia, and in little boys, just check the foreskin. Occasionally you will come across a little boy with what appears to be a natural or partial circumcision appearance. And you usually see that in hypospadias. And very often it can be quite deceptive because you've got this partial circumcision appearance. You look and you can see dimpling right at the end where the meatus is, but in fact there may not be any hole. And if you look back to where this partial circumcision foreskin is, you'll often find a pinhole for coronal hypospadias. So that's something that you need to check on if you've got that partial circumcision appearance. I check the testicles, and occasionally if they're not in the scrotum, they can be up in the canal, and I don't get too excited about it, particularly if I can milk them down into the scrotum, and it's just something that I would check in several weeks' time. With little girls, I just simply separate the labia and have a look to see if I can see the hymen. Occasionally there can be a little bit of blood coming out of the vagina, and that's this pseudo-menstruation that you see in little baby girls, and again a bit of reassurance to the mum that this is nothing to worry about. Okay, have a look at the anus, make sure the anus is patent. I usually recommend to the resident staff that they get a cotton wool bud and just pop it in the anus to see if they can get that anal wink, just to make sure that the anus is patent. There is often a pilonidal dimple, and I usually press on that to make sure that I can see the bottom of that dimple, and if it is just a dimple, it's of no clinical significance. If it's a sinus, and you can't get the bottom of the sinus and it's going right through, then that may be quite relevant with regard to minor spinal anomalies of the lower spine. You can get a pilonidal sinus associated with spina bifida occulta, so that is relevant. But a dimple is of no great consequence. And of course you're well familiar with Mongolian pigmentation, that bluish pigmentation. And most parents are, but every now and again parents are not familiar with that and they think it's bruising. So I think it is fairly important to just reassure them in that regard. I've actually seen Mongolian pigmentation extending right up the back and across the shoulders, but it usually fades as the little babies get older. Okay, so that brings us now to an important part of the examination, which is examination of the hips. And I say to the staff and to the parents that the hip is a ball and socket joint, and the thing that makes the socket or the acetabulum grow is movement, normal movement of the head of the femur in the acetabulum. Consequently, in a breech presentation where you're not getting a lot of movement, you may get a dysplastic acetabulum. And it is interesting to note also that dislocated hip is commoner on the left side, because the left side is often, in an LOA, pressed hard against the maternal spine, so the baby's not kicking around a lot, whereas it's kicking around a lot here. And it's commoner in big babies, for obvious reasons, and it's commoner in twins, because they're compressed in the uterus. So I explain that the hip is a ball and socket joint, and if the acetabulum is shallow, the tendons will pull that hip into a dislocated position which is posterior. It will pull the hip posteriorly. So when we examine the hips, we are attempting to demonstrate if there is any dislocation or if there is any laxity of the hip joint. And this is very important to pick up at an early stage. But of course, in your situation, you may be in a position to pick this up if it's been missed by us. So the manoeuvre that I use, the registrars do it in several ways. You'll see a lot of the registrars just grasp both thighs and they'll abduct one and then they'll abduct the other one. I think that's unsatisfactory because it is possible to have a dislocated hip, and if you don't abduct that hip fully like that, you're not going to get clunking back into joint. So I usually immobilise the pelvis with my fingers in the sacral area, my thumb in the symphysis area, and I gently take the thigh and I'm abducting and pushing up with these fingers. Abducting and pushing up with these fingers in an attempt to clunk that back in if it's dislocated. If you get a clunk, and it's not just a click, it's a clunk. If you get a clunk, that is referred to as a positive Ortolani sign. So that's a positive Ortolani sign. So I'm abducting and I'm pushing up. I also adduct and I push down with my thumb. Adduct and push down with my thumb, because I may be able to demonstrate that even though the hip is not dislocated, it is subluxatal. So I've abducted and pushed up and nothing's happened, and then I've adducted and I push down with my thumb and I get a clunk as you get subluxation of the head of the femur just over the rim of the acetabulum. So it clunks like that and then clunks back in. And that's referred to as a positive Barlow sign. And you will see that in relation to a lax dislocated hip. So it may have been a breech presentation without obvious dislocation, but the hip is lax. So clunk like that is a positive Ortolani sign. Clunk, clunk like that is a positive Barlow sign. I won't spend too much time, but I would immobilise the hips in a pelvic harness for both of those situations anyhow. And the prognosis is pretty good if you pick it up early. Okay, so that's hips. The other thing is feet. We look at the feet and there are several positional situations that you see babies' feet. They can be equinovarus, so equinus and around, equinovarus, and they can be in utero like that, or they can be calcaneovalgus, like that. Now, with equinovarus, in the extreme situation, if there's dislocation at the joint, that's clubfoot. And with equinovarus or significant clubfoot, this requires the services of one of the paediatric orthopaedic surgeons. So equinovarus, I'd usually get one of the orthopods to see because it usually requires serial splinting to get that back in. Calcaneovalgus is a fairly common positional situation. The baby's sitting like that, and normally with calcaneovalgus you find in this position that it's dry and tight. So it's dry and tight because that's the way the foot has been pushed back. And I usually just say to the mum, every time you change the baby's nappy, just stretch that down and around and massage some cream in that area. And normally that's all that is required for mild positional calcaneovalgus. Just stretching down, massaging the dryness in that area. And so the stretching and the dryness usually is overcome by just that those exercises. The other foot anomaly that you sometimes see is actual movement or positional movement of the forefoot, which is called metatarsus varus. And if you look at the bottom, you'll see that the foot is twisted like that, which is metatarsus varus, and that requires the services of an orthopaedic surgeon. I think that that is we can say you can do a fairly thorough clinical examination in 10 minutes or so, and that's about the size of it really. I did want to mention a couple of things that involve you. I've mentioned firstly neonatal jaundice, because a lot of our babies are only staying 24 hours in hospital or even less, and the mean time is about 2 days, isn't it? Yeah. So they're going home to you, at an important time. So neonatal jaundice is one of them, and as I said, a Keffel hematoma can accentuate the mild physiological jaundice, and certainly I think as a figure, a bland figure, if the bilirubin's up around 250 or so, we probably should be seeing them. So if you had a baby that looked jaundiced and it's got a bilirubin of 250 or more, it's probably reasonable for us to have a little look and just see. The other one is renal pelvic dilatation. So common. You're getting lots of ultrasound reports saying that there is mild renal pelvic dilatation. Our approach is, firstly, that we classify mild renal pelvic dilatation as that dilatation in that 4 to 8 millimetre range. Now the literature says about 4 to 10, but that depends on how good your ultrasonographer is. But I'm usually saying about 4 to 8. And our approach there is, if there is less than 8 millimetres dilatation, that baby should have a renal ultrasound at 6 weeks and probably see one of the paediatricians. If it's more than 8 millimetres dilatation, then that baby should have a renal ultrasound at 1 week and probably see one of the paediatricians. The evidence suggests that if you've got a group of babies with renal pelvic dilatation greater than 8 to 10 millimetres and that persists at your 1 week renal ultrasound, then that baby should probably have further investigations, which would include initially a micturating cystourethrogram. So that's it. I couldn't help but pick up on what we're saying about babies and their weight progress, and the other little rule of thumb, because I get so many babies who are having difficulty breastfeeding or even bottle feeding, and they're referred as queried failure to thrive. Now, if you put down their weights, particularly on a percentile chart, in the first 6 weeks, you're not crossing 2 percentiles, so you're not getting a definition of failure to thrive there. And my rule of thumb is usually that a baby should regain its birth weight in about 7 days or so, within reason. Some of the very big babies lose more weight and take a little longer, but they should regain their birth weight in about the first week, and for the next 10 weeks they average 180 to 200 grams per week. So if you see these babes at 6 weeks of age, they should have put on 2 kilograms from their birth weight, roughly. And that's a good rule of thumb, because every now and again you can get this subtle change of failure to thrive. So you see the baby at 6 weeks and it's only put on 1.2 kilograms. So that's a bit sus, but you would push on with feeding routines and try and stimulate breast milk supply, etc. But if it's not gaining on an average about 180 to 200 grams, then it's starting to fit into that poor thriving group. Okay, I think that's it.
Questions?
Any questions?